Well, good evening, everybody, and welcome to Twilight, which I know for those of you on the East Coast is at the special time of 7 p.m. But thank you so much for joining us. We've just gone an hour later because we have literally just finished the closing session of Perthan's over here in Perth. You're in for an absolute treat tonight. Tonight we're doing all things fetal growth restriction. As many of you know, a topic extremely close to my heart. And we have taken advantage of the international speakers which have come to join Perthan's, and indeed the president of Perthan's, who possibly unwisely for her made a decision that she would give a talk straight after the Perthan's closing ceremony. But I'm hugely grateful to them, and I'm so grateful to all of you for joining us. I would like to start with acknowledgement of country. So I'd like to acknowledge the traditional owners of the lands on which we are meeting today. Here we are at Whadjuk Noongar people's land of the Noongar Nation. I'd like to pay my respects to their elders past and present. I recognise their continuing connection to land, waters and community, and I'd like to extend that respect and welcome to all First Nations people who might be with us tonight. So we've got over 1,500 registered for tonight. It's wonderful to have so many of you live online, and please do keep the questions coming in the chat. But we're welcoming people from all over the globe, so I know some of you will be watching at a time that is a little bit more civil for you, but you are all welcome, and as you know, this recording will always be available to you within 48 hours of us completing Twilight. So just a couple of other events that are coming up soon that we hope you might like to join us for. So the Future Fellows Masterclass is pitched at our trainees, those who are about to sit their exams. We haven't had in-person courses for a long time, so Mercy Perinatal's taken it on. We've got a week-long course at the beautiful Langham Hotel. I think we might have 1 or 2 final tickets available. So whether you're a trainee or you're a consultant wanting to do a little bit of a refresh, that'll be Monday to Friday, the 13th to 17th of April, and we'd love to see you there. It's going to be a great update. I'm looking forward to learning a whole lot more. The second thing is the Global Midwifery Update. As you know, this is the Midwife Partner Conference to the Global Obstetric Update, which is now coming into its 11th year, can you believe? This is our second year of GMU. That's going to be held at the beautiful Park Hyatt in Melbourne. We've got all topics that you, the midwives, have told us that you want to hear about in antenatal care, in preconception care, in intrapartum care and postpartum care. I'm talking on sepsis, Stephen Tong's talking on preeclampsia, but most importantly, you are hearing most of the program from midwives for midwives, and we can't wait to see you there. The next thing that I'm very excited about is, as you know, each year I host a leadership program. This is going to be on Saturday, the 23rd of May, and this time I'm co-hosting it with Professor Steve Warrilow from Austin ICU. We've got fantastic speakers from all over the sector, from neurosurgeons talking about mentorship and sponsorship. We're hearing from our paediatric colleagues about social media and how does that fit into modern health leadership. The first-time manager, what do you need to know from the world's best CMO? How do we hold the lantern for difficult conversations with families? And we've got the keynote address from Kirsten Ferguson, who, as you know, is the Times top 50 thinker. And finally, we're going to wrap it up with the CEO is in, where we've got the leading CEOs from Victorian Health Services who are going to talk to us about what they wish they'd known and maybe what they wish we knew as well. The Australian Reproduction Update is going to be held at Pentridge. Seems a little bit of an unlikely coupling that we're going to Pentridge Prison and it's going to be Christmas in July, but I know it's going to work. This is for our leading scientists in reproductive health, but with a really clear view to translation. We get scientists from all over Australia and New Zealand who are coming to join us as keynotes and to present their work. So we'd love to see you there. And then finally, as you know, our hallmark conference, Go You 2026. This year we're off to Broadway, back at the Park Hyatt on the 19th to the 21st of November. So get your dancing shoes on. It's going to be a fantastic conference and we can't wait to see you here. Just to shout out that the Mercy Perinatal Lived Experience Registry is open. We would love to hear from any of you who may have patients or families, or indeed any lived experience experts who are on the call today who would like to contribute to giving us some guidance from you about the what, where, how and why of the research that we're doing. We'd love you to join the registry, whatever your experience of pregnancy, and feel free to click on the QR code. Finally, I just do want to acknowledge the extraordinary support that I and all of us at Mercy Perinatal get from the Mercy Health Foundation and Mercy Health. We couldn't do this work without their incredible support, and we're so grateful to them. So, to our speakers, as I say, they are absolute international gods in their areas. So, first of all, we've got Professor Sanne Gordijn. Have I pronounced it right?
Yes.
Close. She's going to be talking about fetal growth restriction and particularly placental pathology. As you know, she's the lead author from the SEPRA trial, which we talked about at GoU last year, and we mightn't be picking that up today, but we're going to be hearing about all of the placental pathology and how that manifests in fetal growth restriction. Sanne joins us from the University Medical Centre in Groningen in the Netherlands. She's a household name thanks to the Delphi Consensus classification on FGR. Published in 2016, it remains the anchor guideline for all of us in the field, working in clinical and research practice to reduce unwanted variation and ensure standardisation of definitions when managing this common and important placental disease. Next, we are very honoured to have Professor Wessel Ganzevoort from UMC Netherlands, who is going to be talking about that thorny issue, timing of birth in early onset fetal growth restriction. We want to maximise gestation, but not expose the baby to unwanted acidosis, asphyxia and stillbirth risk. So how do we get the timing just right? Wessel is also a rock star in the area of FGR. He was also a senior author on the Delphi Consensus, and he's played a crucial role in major trials that have informed our practice. The CHIPS trial, tight versus less tight control of blood pressure in pregnancy, the Strider Consortium, a search for therapeutic rescue in early onset FGR, and of course the Mighty Truffle Consortium. And finally, we've got Professor Adrienne Gordon, who comes to us from the University of Sydney and RPA. Adrienne is the current president of PSAN. She's had a very busy 5 days, and she's a lead investigator on the Stillbirth Centre for Research Excellence. There are a few who stand so capably and with such extraordinary energy on the bridge between pregnancy and newborn care, and her incredible output's a testament to her capacity to build collaborative networks. Adrienne will be talking to us about fetal growth restriction after second stage, taking us on a journey of newborn life and beyond for babies who've experienced placental insufficiency. So we're in for an absolute treat tonight. Settle in, grab yourselves a coffee or a wine on the couch, and I'm going to hand over to Sanne.
Thank you very much for the introduction and also for the opportunity to present some of my work here today. So my name is Sanne Gordijn, which is quite difficult to pronounce if you're not used to the G. I'm indeed from the Netherlands, in Groningen up north. So I have no conflicts of interest to report, except for the fact that I really, really deeply love Australia. I've lived here for a year. I do have some financial and in-kind support for my studies, but they are no relevant to this presentation. So some background. I was born in 1978 from DCDA twins. My membranes were ruptured at 26 weeks of gestation, and we were born at 34 weeks of gestation. My birth weight was actually quite okay. It was 2.1 kilograms, and my twin brother was really small, almost 1.7 kilograms. So he was growth restricted. So you can see us in the picture. I'm the hairy one, he's the bald one. Eventually, he's actually 1.91 meters, and I am only 1.68 meters. So he won eventually. In 2001, I started to do research, and I did this with Professor Yi Kong, who was located in Adelaide. And he has also been my supervisor for my PhD thesis that I finished in 2009. And I'm very proud that we also wrote a book together about placenta pathology. Another thing that I'm very proud of is my contribution to 3 placentas. And the owners of them are 17, 16, and 14 at this point in time. So fetal growth restriction is a difficult topic in a sense that it is not similar to small for gestational age. So historically, we defined fetal growth restriction as small for gestational age, which is quite easy because you have a number and you can calculate whether you fulfill the criteria by looking at the weight for gestational age for a baby and then indicate whether or not it is within the normal range or whether it's too small for gestational age, and then you say there's fetal growth restriction. But we know that the concept is a little bit different. So fetal growth restriction is always pathological, and it means that you're not reaching your own intrinsic growth potential. Small for gestational age is quite simple. It is an abnormal size for gestational age based on a reference curve, usually we indicate it as the smallest 10% of a population. And fetal growth restriction is a multifactorial disease. Actually, it is the result of placental dysfunction, but we don't have many markers that can indicate placental dysfunction. So we take the only one that is reasonably well, at least in history, that was the only thing that we could measure. These days, fortunately, we can do some more. Once more, it is easy. If you use small for gestational age as the definition, it's easier to diagnose it than what we do now, use multiple markers for the diagnosis. And of course, there is correlation with smallness and pathology. And this figure nicely illustrates the concept. So on the x-axis, we have the weight percentile, and on the y-axis, we have the incidence of growth restriction. Looking at the weight percentiles, we see that small for gestational age is the smallest 10%, normal is 10 to 90%, and large for gestational age is above 90%. So historically, this gray area would make up your population of fetal growth restriction because that's the small for gestational age group. We think that the incidence actually is more similar to what I colored in this figure. It is also around 10%, but it's not the smallest 10%. What you can see as well is that the smaller the fetal size, the higher the chance that there is a growth problem. So there is a correlation, but it's not a one-on-one correlation. Taking back the small for gestational age demarcation into account, you can see that in the red striped area, those fetuses will be diagnosed with fetal growth restriction, but they're in fact healthy small for gestational age. So they met their growth potential. And then above P10, you can see that the blue striped area, they are the fetuses that did not meet their growth potential, but they are seemingly normally sized. So you wouldn't recognize those. The risk for the healthy small for gestational age, at least in the Dutch setting, is that they can't deliver at home anymore. So they're in a hospital setting rather than in a low-risk situation, and delivery at home would be possible if we would have known that they are actually healthy. The undiagnosed group is the group that might suffer from intrapartum hypoxia or might even die, and we don't grasp the fact that they are actually at high risk. So it's important to realize that this actually might be the situation rather than the small for gestational age. To further illustrate this concept, I've made three growth curves, and there's a yellow baby that starts at P90 and then declines to P30. There's a blue baby that starts at P50, then grows, the size is a little bit more than P50 and then declines to P20, and there's a red baby, and that grows along the line of P10. So what you can see is that the smallest baby in this graph is actually the most healthy one because it's growing along its own line. So this is just to further illustrate the concept. In 2015, and Sue already mentioned this, we performed the Delphi consensus procedure to further specify what fetal growth restriction would look like, asking all the experts in fetal growth restriction studies at that point in time. And the good thing about what we came up with was that not only small size, but also functional markers of the placenta would indicate fetal growth restriction. For example, if you look at the early fetal growth restriction, which is below 32 weeks, an absent end diastolic flow in the umbilical artery would immediately identify you as growth restricted, meaning if you're at P60 or P70 with an absent end diastolic flow, your growth centile doesn't matter. On the other side, also, if you're mildly small, below P10 and not below P3, because P3 also, as a solitary marker, identifies you as fetal growth restriction, combined with abnormal Dopplers in the uterine artery or umbilical artery would also together form the diagnosis of fetal growth restriction. And something similar accounts for late fetal growth restriction, where a decline in centiles combined with Doppler abnormalities would provide the diagnosis. So there's many factors that actually influence fetal growth. We have maternal factors, for example, autoimmune disease or infections or drug use, fetal factors that are mainly genetic or syndromal factors, and placental factors. And that last one is my favorite topic because I'm a great fan of the placenta. So the placenta is the best organ we've ever had, and we sort of cut it off and then throw it out, which is really terrible, actually, because we need separate organs after that to take over the function of the placenta, for example, intestines and lungs. So in Dutch, we call placenta a moederkoek, which would translate to mother cookie, which is really not the right term because all the structural cells in a placenta are actually of fetal origin. So if you do a Gordian-Phillips biopsy, you do it to see the genetic makeup of the fetus and not of the mother. So we should call this a child cookie if we use the word cookie anyway. The placenta is kind of a messy organ because it's sort of a disposal organ. So it is built in such a way that there's many structural mistakes, but because there is overcapacity, it can actually compensate for that. There's two separate circulations. So there's the fetal circulation, which is completely separate from the maternal circulation. And the fetal circulation is in the villus tree. So around that, there is the intervillus space, and there will be the maternal blood. So the maternal blood is there only as a guest. There is a specific way for the placenta to grow, which is kind of difficult because the area is confined. At a certain point in time, you can't make more placental tissue. And what happens then is that the maturation of the villi actually makes sure that the demands of the fetus are met. And the demands of the fetus are actually, there are three important things. So there is nutritional demands, there is gaseous demands, and there is a need for maturation. And looking at this graph, you can see that initially there is a very steep rise in the needs of placental needs for nutrition. So it flattens down towards the end of pregnancy. And if you look at the gaseous needs, that initially is quite low, but then a steep rise at the end of pregnancy is seen in this graph. The purple line is the need for maturation, which is actually sort of the problem for the obstetrician, because if we wouldn't have had this need of maturation, we could deliver babies at any time we would like, and then hand over to the neonatologist, because then feeding and oxygenation would be taken care of. But this line actually is the reason why we are always sort of struggling in when to induce labor or when to await spontaneous labor. So the placenta is made of 3 layers, and the colors that I use here, you will see them along my presentation all the time, so you recognize what I'm talking about. So there's a gordial plate, which is the part of the fetus, and the chorionic vessels are there. Those are fetal vessels, and the membranes are there. Then there's parenchyma, and parenchyma consists of the villi. The villi are of fetal origin, have the fetal vessels, and there is also the intervillus space, which was separated from the fetal part. So there is maternal blood, which is there only as a guest. And then there's the basal plate, which is the area that is formed by the decidua, and there's the spiral arteries of the mother that need adjustment, and the anchoring villi of the fetus are actually nested in that area. So those 3 areas are important. If we look at the placenta when it's born, you see here the fetal side and here the maternal side. So using the colors again, green area is fetal side, blue area is maternal side. And there's different ways of transportation across the placenta. So there's the fetal circulation that transports waste and carbon dioxide towards the placenta and takes away nutrition-rich and oxygen-rich blood from the placenta that has been fed by the maternal blood that was in the intervillus space. And the parenchyma is actually the area where the transportation occurs. So there is active transportation, which means that there is ATP facilitating pumps or channels that actually cost energy to transport molecules across. For example, which is very interesting, glucose. This is performed by active transportation, meaning that even when there is low oxygen, you can still proceed to do this as long as there is energy. So active transportation is one of the forms, and then there's facilitated transportation that costs a little bit energy, but not so much. And then there's several ways to do this facilitation. And finally, there is passive transportation, which is very important because this is oxygen transportation. So oxygen cannot be transported across a channel that needs energy. And this is really important because if the oxygen transportation is not possible due to a longer distance between the fetal and maternal circulation, there is no option to compensate for it. And diffusion means that the transportation goes against a gradient, so the lowest concentration actually draws oxygen towards that area, and the highest concentration actually provides it. So we go back to the basal plate. So that was the blue area, the maternal area. And this is a very important part of the placenta, although it is maternal. In the non-pregnant situation, this is a spiral artery, this is in the myometrium, and you can see smooth muscle cells that are along the spiral arteries, and they, because they're still there, they can contract based on what happens hemodynamically. In a pregnant situation, there are cytotrophoblasts. Those are actually fetal cells that destruct that area. So the vessel wall is destructed by cytotrophoblasts, meaning that the smooth muscle cells are destroyed and they are no longer active. So that eventually results in a low flow, high volume circulation towards the intervillous space. And this is a very important step because if you have not well adjusted spiral arteries, there will be a different way to supply the intervillous space. So if you compare it by watering your plants, you would need like the spray cap to water your plants and not a high pressure tool, because then you would destruct the plants. And here you can see that the villi, so those are the fetal vessels, there is the supporting cells, and this is marinated in the maternal blood. The maturation process that I told you about, which is very important, is shown in this picture. So initially, early in pregnancy, those villi are formed. They are stem villi. And what you can see, this is a fetal vessel, those are cytotrophoblasts, this is syncytiotrophoblasts. And what you can see is that there is not much surface area of the fetal vessels, and they are far away from the intervillous space. Later in pregnancy, when the process of maturation occurred, you can see that there is a lot more surface area available for the fetal vessels. There is only little supporting cells, and the syncytiovascular membrane is very thin. So here, the transportation exchange area distance is very low, which is very important. So there are many factors that can reduce placental function, for example, low placental volume, abnormal structure, or increased distance or decreased exchange surface area. And there are many reasons for it, but those are the most important reasons. Now we get to placental pathology, and I experience that many people think it's quite difficult, but it's actually not. So we go back to the colors again. If there is in the basal plate, so that was the maternal area, the blue area, if there is a problem, we call this maternal vascular malperfusion, meaning from the maternal side, the perfusion is suboptimal. On the fetal side, it's called fetal vascular malperfusion, which is obstructed flow on the fetal side. And then a little bit more difficult problem is in the intervillous space or the parenchyma, which we call usually inflammatory lesions. And there's another group which is called other lesions. If you look at the associations clinically with the placental lesions, you can see that fetal growth restriction actually is a condition associated with any placental lesion, except for acute inflammatory lesions, because that usually results in preterm birth. So maternal vascular malperfusion usually happens due to incomplete or non-existent spiral artery remodeling. And this is the most famous placental lesion. So In the next slide, I'll show you what it looks like, but it means that the blood volume that is transported into the intervillous space goes under high pressure and it's low volume. This results in a ischemia reperfusion damage cascade, meaning that also the villi, the fetal villi, do not develop properly and they are harmed, meaning that there is also scar tissue on the villi. What happens then is that the villi try to compensate for that and they start to mature in a faster way than normal. But there is a maximum to that capacity to mature. So you will reach your end stage of maturation earlier than at term gestation. And usually because the placenta is not developed properly, it is a smaller volume as well. So if we go back to the normal situation, we have the cytotrophoblast destruction of the vessels and a normal flow into the intervillous space with the villi marinated by the maternal blood, a normally shaped villus, and then we see what happens in the abnormal situation. So the cytotrophoblast does not properly model the spiral artery, so there's a jet stream into the intervillous space. The villi are smaller, they're not developed very well. Because of their increased maturation, you see that the cells sort of try to regenerate fast. There's a lot of waste tissue into the maternal situation, which often leads to preeclampsia. And then eventually the villi get destructed. So that would we call as an infarction. Another item that we can see, and you can imagine that, is that there's a higher chance of hemorrhage. So there's intervillous hemorrhage, meaning that this stream actually damages something and there will be a bleeding in parenchyma, and also retroplacental, which means an abruption. Looking at the placenta macroscopically, you can see that there are infarcts, and you can see here what it would look like. So there's a problem in the spiral artery, then this part will be taken out. And you can see if you cut the placenta in slices what happens. So here's a fresh hemorrhage. You can see the parenchyma is actually compressed and eventually it will result in infarct. So this is what it looks like a little bit later when you wait a few weeks. So there's very nice pictures online available if you're interested in it, what it would look like under the microscope. Also, the decidual arteriopathy is the maternal aspect, but it is very difficult because you don't have them in your histological slides all the time, because there's not so many spiral arteries that every slide will contain a spiral artery. So this is just to illustrate that it's quite easy to recognize under the microscope when there is a maternal vascular malperfusion, because you see that the distribution of the villi is very suboptimal. There is not so many, they're way smaller. And what you see here, like the purple areas, this is the excessive maturation. So they are called Tenney-Parker changes, and that is like waste material of cells. So fetal vascular malperfusion, which was the green area, so the top layer, the fetal area, that can occur if, for example, there's hypercoiling or hypocoiling of the umbilical cord. You can imagine that the blood flow will be obstructed. Also with filamentous insertion, you can imagine that it's way more difficult to transport the blood across to the parenchyma than when it's in a central position, and thrombosis can occur for several reasons. So there will be obliteration of the vascular system, which can also happen in a lesion that I will discuss next, but that's then secondary to the inflammation. So again, it looks like normal on the left side, and then what it looks like under the microscope if you would have a look. So here is obstruction. Then, of course, when there is no blood flow into that area, the villus will be destroyed. There will be no vessels or only a small vessel. Initially, there will be some remnants, and then later on, it will be destructed. Also, there will be fibroblasts around that area or in that area. It will look like this on the macroscopic evaluation. Here you see a very large distended vessel, which is due to thrombosis. So first there is congestion, and then when you wait, you will see that the area below that will be destructed. So this is laminar necrosis. There's many fibroblasts in that area and it's dysfunctional. Here you see another form of thrombosis where there is no blood flow possible anymore. This is what you can see if there is a hypercoiling of the umbilical cord, so there's too many coils, and you can see there has been congestion. And what you see here, the brown color is hemosiderosis, meaning that HB is pushed out of the vessel. Also this, you can, if you like, look up. There's many slides showing what it will look like. I have an example here. This is the normal situation with the normal villus, and here you can see the fetal blood vessels. Here you see there's no blood vessels at all. So you do see the structure of a villus, but there is not a blood vessel. So finally, the chronic inflammatory lesions, that is the third group that is associated with fetal growth restriction. There is destructive inflammation, and usually it's phlebitis of unknown etiology, so we don't know what the etiology is. And the situation is quite specific because there is CD8 positive maternal cytotoxic T cells in the villi. And usually there are no cells crossing the syncytiovascular membrane, but those cells do cross, and then they destruct the villus. So once more, the normal situation, and then compare it with the phlebitis of unknown etiology. Here you see that the CD8 positive maternal cytotoxic cells, you see the vessels that are destructed, and eventually there will be scar tissue or fibroblasts as well. And it will look like this on your histological slide. So here you see abnormal fields of maternal cells. So how can we detect placental pathology in clinical practice? Because the placenta is always investigated after birth. So we know that we do biometric measurements. They are not so very reliable. The other thing that we can measure are Doppler measurements. So you want a low resistance circulation through your placenta, which is reflected by the umbilical cord pulsatility index. So you would like a low pulsatility index of the umbilical cord. The other item is a proxy that we measure, which is the middle cerebral artery. So if your resistance in your brain is normal or high, it's not a prioritization of that organ. So that is the situation that you would like. But if the vessel is dilated to prioritize the brain, there might actually be a problem. Also, these measurements are not so very reliable, but I think the trick will eventually be in combining many factors. So you need an algorithm to eventually decide whether a fetus is at risk or not. So I hope in the future that we can do some measurements related to volume of the placenta and also the microstructure of the vascular tree of the fetal site. And then I think combined with umbilical cord measurements, amniotic fluids, maternal factors, things like that, and then we might be better off. So on ultrasound, you can see the intervillus bleeding that I showed you before. So it would look like this on a slide if you just cut the placenta. And here you can see that the parenchyma is already compressed. So this has a reduced function. I'm sorry. And then here you see the filamentous insertion, which you can imagine that it's way more difficult. So that's fetal vascular malperfusion that you're waiting for. And then there are more rare lesions that are in the other placental group that I didn't discuss, but for example, choangioma, mesenchymal dysplasia, and of course the placental abruption, which is also hard to detect on ultrasound, but you could see a blood clot which is behind the placenta. So in conclusion, fetal growth restriction is in fact placental dysfunction. We're not only looking for small size, we do use small size as an identifier to estimate a higher risk, but it's not all in small size. We have different functional markers and they can be identified by ultrasound. Placenta pathology underlying growth restriction is diverse, and there's the big 4 placental lesions, maternal vascular malperfusion, fetal vascular malperfusion, and inflammatory lesions, and of course other. Thank you for your attention.
Furious applause from all of us in the room here. Sanne, thank you. That was just a wonderful overview of where we are in understanding the difference between small for gestational age, the proxy that I guess we use for decades, and that guidelines still rely on in a lot of health services, but the important multi-parameter assessment to comprise fetal growth restriction. I love the purple, the green and the blue, and your classification of placental disorders, I think, has finally helped all of us make some sense of it. Once we've got the placenta in the pathology lab, it's not quite so difficult. When we've got a mum who's still pregnant, you touched on biomarkers, and I guess the one that's sort of the flavour of the month at the moment is placental growth factor, and then I guess uterine artery Dopplers as well. And I guess, would it be fair to say that they may be quite discriminatory for maternal vascular malperfusion? Where do you think the role is in helping with the other placental pathologies, the fetal and then the placental lesions?
Well, I think that what I always try to do is think of the biggest problem, which is, for example, diabetes. There's must fetal growth restriction. There's many people who have a higher than average glucose level. And as I told you, the glucose is transported actively. Placental growth factor, in my opinion, is mainly reflecting placental volume rather than placental function. So it can be one of the factors that we measure, but we have to rely it on other measures. So the S-FLIT is really important as well. So if you have a diabetic mother, placental growth factor can actually be quite high because there's a large placental volume, but her risk might be higher for fetal demise because of the distance between the maternal and fetal circulation, because the maturation process of those villi doesn't happen very well. So I think placental growth factor alone is not sufficient. I think there's sort of, Wessel spoke about the placental weight, birth weight ratio and how you can use it. It doesn't say enough. So also placental growth factor could be one of the factors that we have to take into account, but I would not put my money in it if I would only be able to measure one thing.
Well, for sure. And we know that it's very gestation specific in terms of when it's got the most use as well. And so we and others, as you know, are looking for better markers, particularly in late pregnancy, where, as you say, the markers of smallness and the Doppler markers become even less reliable than they do preterm. I'm just going to go to the webinar. Lots of thank you for a fantastic presentation. All very true. Thank you for the comments. There's a question from Caitlin about, does the Delphi consensus still recognise asymmetric and symmetric? So I guess this is getting at that abdominal circumference under the third, estimated fetal weight under the third. How are we using those two measures?
Well, actually, the Delphi consensus does not cover that specifically because it uses the several items. What it does is that the AC as an item separately counts irrespective of the size of the head. Yeah. We didn't cover it. It was complex enough, and actually Sue is involved in the next update procedure because we're about to launch the questionnaire to invited fetal growth restriction experts to see whether the definition is still good enough or whether we have to make changes. So it doesn't take it into account, but because we use MCA as a Doppler marker as well, I think that one will actually cover it.
Great. So if you're a growth restriction expert and you get our questionnaire, answer it. Isn't that right?
Please do.
Because we really need to know what do we feel is working in the field. And obviously there's been a bit of a move with your trial with ratio 37. We've got to try and integrate all of that information as well. So it's going to be a lively meeting in the Netherlands later this year when we try and nut all of that out.
Yeah, and maybe for the people that expect the results of the CIPRA, I can sort of very in one sentence tell you what the results are. So CPR-based management in late pregnancy and term pregnancy and non-SGA fetuses actually improves neonatal outcome. So it was not in this presentation, I presented it at SANS, but the summary is that it actually works if you apply CPR measurements.
Great, thank you. Denise has said, and this is probably almost a question for Wessel, who presented on exactly this at PSANS, but about recording placental weight. And I asked exactly that question. Is it time to go back to it? You know, this placental to birth weight does seem to give us additional information about a baby that is comparatively poorly nourished compared to how it should be. And although, of course, by the time the placenta's out, the stillbirth risk has passed or it's happened, but maybe there is still information about neonatal morbidity related to placental dysfunction that might still be of benefit to know. So I don't want to impose more workload on our completely overstretched midwives, but I'd love to have a placental weight. What do you think?
Yeah, I would advocate for some details of placentas, although if we just decide to take all placentas in 1 year in the Netherlands, we would have sufficient information to do some analysis, but not only placental weight, but also the diameter and the surface area, because if you have 500 grams placental weight and it looks like a mushroom, it's very different in function than it looks like a pancake. Yeah. So if you're going to measure weight, please also measure the surface area and the thickness. And I think we do analysis about it, so it would be interesting to collect it and then at least state whether you have trimmed weight or whether you have untrimmed weight and whether you measure it after formalin or before.
Yeah, very good point. And look, I guess, there's exciting research, I guess, coming out of Wellcome and other things, looking at how can we better assess placental size in addition to function, during pregnancy. But you're right, the placental thickness is actually something that's not too difficult for us to do during prenatal life. And so it's really small globular placenta. That's certainly worth something for us to take notice of. Yeah. Yes. Great. We could talk about this all night, but we won't. We're going to pass on to Wessel, who's going to take us through the next chapter of fetal growth restriction, triggers, timing of delivery and early onset fetal growth restriction. But Sanne, absolute joy to have you with us. Thank you so much for joining us. We really appreciate it. All right. We'll hand we have controls over. Oh, you've got a few extra slides there. Always the prudent presenter who has the backup slides for the thorny question. I love it. Great. Thanks, Wessel.
Thank you for the introduction, and also thank you for the invitation to speak here today in this webinar. Where's it going? There. So I also have no relevant conflicts of interest, other than that I'm really interested in the topic, and I do have some commercial collaborations, but these are all investigator initiated and do not pertain to the current presentation. So I think I'll go over this really quickly, because placental insufficiency is at the heart of early onset fetal growth restriction, but it has already been dealt with by Sanne. And so the major part of this problem is maternal vascular malperfusion. It's at least the most commonly underlying mechanism. And but the essence of it is incomplete placentation in early onset pregnancy and subsequent damage to the placenta in the second half of pregnancy or starting second trimester. And early onset fetal growth restriction has a very specific clinical dilemma. It's not the diagnosis that is difficult, it's the treatment. Because the diagnosis is usually very much in your face. Fetuses that have this problem, they usually show all textbook signs and symptoms of the underlying pathology. An abnormal uterine artery as a reflection of incomplete placentation, and lots of findings that we can relate to the compensation mechanisms that the baby actually applies in order to survive the adverse intrauterine milieu. And also, of course, particularly in early onset fetal growth restriction, there's a large overlap with maternal hypertensive disorders, which are a result of placental damage and metabolites from that damage entering the maternal circulation. And as Sanne also indicated, there are a couple of functions of the placenta that are really important in this aspect. So first of all, it's the metabolic function, which is required because because the baby does not only need to sustain his life at this point, but is a very rapidly growing organism, sometimes 10 to 15% each week, which is a tremendous effort. And then once that is not optimal, this fetuses will become very much smaller than the typical gestational age peers. But to a sense, this is rather, this is so you stay small. Is that all? Well, the biggest issue is that once it's not just the metabolic chain that does not provide what a fetus needs, but it's also a respiratory chain that starts to fail. This means that the fetus will develop hypoxia, and then that is related to the immediate outcomes of stillbirth. So if we want to prevent this, this is where the difficulty is, when to actually deliver this baby. Fortunately, it's a very rare phenomenon, so approximately 3 to 4 per 1,000, but the mortality is really high. And once we have delivered a fetus, usually with a cesarean section, because it will not be able to sustain the complications of the challenges of a normal vaginal birth, it's still only it's still not said that baby will actually grow up to a healthy pink neonate at term age. So it's really the end of the spectrum. And there have been quite a lot of trials to try to ameliorate this situation by actually improving the function of the placenta. And one of the ideas was that because there's retained vascular contractility, that sildenafil, which is a very powerful vascular relaxant in the uterogenital area, maybe that could improve. And there were a couple of cohort studies and small randomized trials that sort of suggested that maybe sildenafil in this situation would improve fetal growth. And as a I think very good example of collaboration around the world, there were 5 planned Strider trials, so the sildenafil trials that were initiated at more or less the same time, of which 4 actually started, and among those of course, was the one in New Zealand and Australia, led by Katie Groom as well. And one was in the Netherlands. There was a Canadian trial that started, and there was the UK trial that came out first. And the idea behind this was to also be able to do a pre-planned individual participant data meta-analysis. And to cut the story short, it did not work. Well, probably most other potential medical interventions also are not very convincingly proven to be of any benefit yet. So we recently finished this IPD, and we hope it will be published soon. So this looks like a very complex slide, so I'm sorry for that, but really there are, in our balance of when to expedite birth, we need to weigh all different risks that are either associated with hypoxia or with prematurity. And the difficulty of that lies really in the weighing of those risks, first and foremost, because it's sometimes quite difficult to really assess the exact magnitude of that risk. But it sometimes feels like the old mythological Scylla and Charybdis sailing between those two dangers and trying to weigh this as best as we can. And I think a very important hallmark trial in this patient group was GRIT, which was a trial in several European countries where women could be randomized if the clinician was unsure whether or not to deliver this fetus. So if it was black and white, so if there was an really abnormal CTG, of course the baby would be delivered. But there was also, for instance, in the Swedish practice, it was common to deliver babies when there was a clear case of a infant that was fetal growth restricted with abnormal Dopplers. And so there was a considerable doubt what to do, and the women were randomized at that time. And when you looked at the outcomes, and particularly, of course, the earliest group between 24 and 30 weeks were most interesting. You could see that the number of deaths between the two groups were not so different, but there was a difference in the neurological outcome. And 97 against 99 may not seem so such a very big difference, but if this is how your mean shifts, this has a significant impact on a lot of babies. And then when we look at this, and maybe to go back, the immediate group here is women who were delivered immediately, and there was approximately a 2-week difference, whereas in gestational age at birth, compared with the deferred group who were only delivered once the clinician was no longer unsure whether or not to deliver the baby. And if you looked a little bit closer, also at the developmental problems such as cerebral palsy and or abnormal developmental score, you could see that there was a 16% versus 6% in the immediate versus the deferred group. So there's the same perinatal death, which is mostly caused because we are shifting antenatal death to neonatal death. So what if we keep these babies alive for a little bit longer, or we monitor them closely during pregnancy a little bit longer, but we try to improve our timing of delivery, actually preventing the stillbirth. In that way, we would also decrease the number of stillbirths, and while getting better outcomes for babies. So this for me, and also how I explain to my residents why we do what we do in terms of using our monitoring science, was this longitudinal cohort study from the early 2000s, where data from 93 fetuses with 3 or more sequential observations was used to look at the pattern until delivery. And if you look at this figure on the right is day 0, which is the day of delivery, and then once you go to the left, it's the various monitoring phenomena that we have used. And for each of those, there is 2 standard deviations above and below the normality. And what you could see is that, for instance, the umbilical artery PI in all these fetuses was abnormal, and it did become more abnormal, but there was no striking difference between, let's say, 30 days and 2 days before birth. So this one is not really useful to actually time birth on. And the same goes for middle cerebral artery and amniotic fluid index. They are low, but they stay low, and there's no dramatic change just before birth, which could then serve as a birth indicator. And there is a good chance that the STV, short-term variation, which is a computed number that sort of characterizes the fetal heart rate variability, as well as the ductus venosus, the PI, which is a vessel that is still present in the fetus, but no longer once we are born, because it obliterates. I'll come back to that later. Those two become abnormal just before there are repeated decelerations on the C2G, and could therefore be used to improve our timing. So we today, and I'll also explain later why, we use those to time birth. But for instance, we use the umbilical artery PI to time the corticosteroids, because once we become less and less certain that sudden abnormal C2G is there, we want to prepare our fetuses with corticosteroids for optimal neonatal course. And we looked at the different options to time our corticosteroids, because there was quite some variation between the different Dutch centers, in the sense that some centers timed their corticosteroids based on just an abnormal umbilical artery above the 95th percentile. And we had Meta collect the data of over 1,400 patients retrospectively, of which 871 were in a center that timed corticosteroids based on an abnormal umbilical artery above the 95th percentile. And then, of course, after that, the classical monitoring was with C2G, and a lot of outcomes were collected. But there were also 580 fetuses who eventually got corticosteroids, or their mother got corticosteroids because at a quite later stage, which was absent end diastolic flow, so a little bit worse in the umbilical artery. And we compared the outcomes in that. But what I wanted to show you predominantly, because that follows from this graph, you can see that the time of interval between the first dose of corticosteroids and actually giving birth was absolutely not different between the Dutch centers. So so apparently there's something else that's happening there as well. And also this did not translate into any differences. So you can choose either as your main strategy. Now, regarding timing of birth, which I before said that we like to use the ductus venosus and the short-term variation. This is a graphical representation of what is the ductus venosus. So from the placenta, the oxygen-rich blood comes into the venous circulation. There's a large proportion that actually goes to the liver, but there's a small proportion that goes from the umbilical vein and travels into the right atrium. And it's actually kind of a nifty design, if you would have, if you believe in that somebody actually designed it. Well, he or she did very well, because actually this oxygen-rich blood is preferentially aimed at the foramen ovale, which is one of the shunting mechanisms of the fetus. So it's very, very nice, and it's not so, if you're an experienced sonographer, it's not such a very difficult measurement. And what we can see here is in the ductus venosus is a reflection of the right cardiac function. So it's the right atrium, and it has influx of blood from that circulation. And in the different phases of the trial of the heart cycle, you can have a reflection of what is happening in that right side of the heart. And you can imagine if there's cardiac failure, that during the atrial contraction, the blood inflow into the right atrium is decreased a little bit more, or maybe even reversed. And these are both states that we recognize as imminent cardiac decompensation. And you might think that some fetuses who are pumping against a very large resistance may at some point in time no longer be able to do this and decompensate, and for that reason at some point in time become hypoxic. So once this occurs, maybe you should take the baby out. And based on that hypothesis was the truffle study. Well, unlike what I've learned from Ben Mol is that every sane trial has two arms, just like a leg, just like a person. But in this case, there were three arms to this trial, which did deliver actually some interesting information. But the three arms were that in one arm there was a computerized CTG used just as the main measurement of fetal function, and in the two arms there was either an early change of the ductus venosus or the late change of the ductus venosus to additionally indicate the birth once they would become abnormal. And the primary outcome was neurological at 2 years, Bailey's, and a secondary outcome was the short-term morbidity and mortality, which was of course reported on first. And in this trial there were I'm seeing that it's not really showing really well, but I'll go to the next one immediately, because this is what the essence is of this. So this is the survival without severe neonatal morbidity, and particularly in the lower gestational ages. At that time, we were used to seeing worse numbers than 30% survival without severe neonatal morbidity in the 26, 27 weekers. So this was actually much better than expected. And one of the hypotheses that we have, because this was in all this was in all three groups lumped together, that this may actually have been a result of standardization, of actually prescribing when to do something in this rather messy world of inter-observer variation and different interpretation by clinicians. And when we looked at the primary analysis of the outcome at 2 years, what you could see, and that's the graph on the left, that is that there was a trend towards well, I should actually say there was no difference between all three groups, but what you could see is that if you would only look at the survivors, that there was a better neurological survival in the ductus venosus groups. Of course, you can't really say for sure that it then works for everybody, but it did require some post hoc analyses that we then performed. So one of the things is that in the truffle trial, only 32% were actually delivered because of group assignment, and this was particularly important in the ductus venosus group, where only a minority had an abnormal ductus venosus measured before the CTG became abnormal. So this suggests that there's a dilution of the treatment effect in the ductus venosus group, because you're not really seeing the difference. There was no randomization at the point of time when the ductus venosus became apparent, but the randomization was done much earlier. So there's a dilution, most likely. And the other thing is that we looked in detail at the deaths that occurred in both arms. So if we look, there was a slightly higher antenatal death in the ductus venosus group, and we had all the CTGs of those, and those fetuses would also not have been delivered if we would have used the very strict SDV criteria in the other arm. So we postulate that it may have been a chance finding, and this is even stronger if the group was then limited to the youngest fetuses. So without being able to say it for certain, there's a good suggestion that an early onset fetal growth restriction with an abnormal ductus venosus, expedited birth likely improves outcomes. Then to the other measurement parameter, monitoring parameter, this is the computerized CTG, or also short-term variation. So this is the calculated variability of the CTG. We always like a lot of variation. And it's important here, I think, to once again mention that we stand on the shoulders of giants. And in this case, it's, for instance, it's Christopher Redman, Professor Redman, who passed away a few years ago, but on whose findings and his development of the Dawson-Redman algorithm was really important in helping us with a lot of physiological understanding of what happens in these babies. And STV is essentially a series of calculations of variation in short epochs of almost 4 seconds, and then there's a calculation of how much variation there is over time. And what is really helpful is that you get a number, and people in clinical practice, particularly less experienced people, really like numbers that they can rely on and use as a fixed algorithm. Now, the ISROC has delivered very firm recommendations that if you are managing in tertiary care, then you should be using CCTG, and this is also in a NICE guideline for the UK. And then the statements are always referencing truffle, but it should be noted that truffle was not a comparison of CTG versus no CTG. It was a comparison of CTG versus CTG plus ductus venosus. So this was not a one-on-one comparison between no or yes CTG. And we did a systematic review to look at this, and actually, of course, we found that there was a good prognostic accuracy of short-term variation for adverse outcomes, but we found no head-to-head comparison. And we did something to sort of aim to make to make such a comparison in an indirect way by using individual patient data from the Truffle and the GRID trials, the two hallmark trials up to that time. And this is in the table. Again, alive with normal development at 2 years. The first column is the results from immediate delivery, and you could see that's about 70%. Now in GRID, it was not prescribed to use short-term variations, so there is a comparison that we could make between centers who do not use STV in the second column, or who did use CCTG in the third column. So you could see that the alive with normal development increased from 69 to 80. And then in Truffle, of course, it was prescribed in everybody, and that led to 77% alive with normal development at 2 years. And then also here you could see that it was slightly better if ductus venosus was added. Now a picture again says more than 1,000 words, so this is how it's translated. If you look at the adverse outcomes, you can see that by adding STV and then adding ductus venosus in both steps, you can see that the adverse outcomes become less frequent. So my conclusion from this is that this is a very dodgy way of comparing things. We should not make more out of it than we can, but at least there is a suggestion that if you use CCGG, you get better outcomes than if you just do the visual analysis or the eyeballing. And that has also led us to, and if I have some time left, I'll talk shortly about the trial that we have started on that in the European context now. Something practical, and this is about how often you should be doing your CCTG. This is an analysis of 500 patients and many more CTGs, again, starting on the right side, the moment that there is repeated decelerations and the baby being delivered, or if there's inactive management, the baby dying, and then what you can see is that if you go back in time, that the short-term variation is more or less the same across time until the last CTG, which is severely decreased. So you cannot really predict your STV change. So once you decide that you want to monitor this fetus really closely, our conclusion is that you probably need to do it at least on a daily basis. And then one other common misconception that I would like to pay attention to is whether or not you can use, or whether or not you say, well, I've given corticosteroids yesterday, now the short-term variation is really reduced. Should I keep this baby in, because isn't it related to the corticosteroid therapy? And there are two answers to this. And these are data from 406 women, 211 with preterm labor, just spontaneous preterm labor in blue, and the green ones are in green. Sorry, are the fetal growth restriction. You can see that the short-term variation is in general slightly lower than in preterm labor. And you can see that here we start on the left when before steroids, and then after steroids, the first 12 hours. You can see that there's a slight increase. It's statistically significant, but not clinically relevant. And the same goes for indeed after 48 hours to 60 hours. There's a very small decrease, but it's really very small. And and the trick that we did here is that we took out all the fetuses who had a C-section because of repeated decelerations in the first 48 hours. So because these were the ones who of course were very likely to have hypoxia. And we took them out because we think that based on these two analyses, that the lower STV that was indeed much stronger in that group is actually confounding by indication. So if you take out the indication of those who are actually for who you actually gave the corticosteroids, then it's no longer there. So this is the time usually when I present, because this is a slide that sometimes comes back when usually my PhD students start rolling their eyes. But this is how I like it as an analogy. So as you know, the Netherlands, we are far below sea level, but we are also being rained upon a lot. And so we have a rain climate. So once we've established with these fetuses that there is that this fetus is small, and we need to look if there are any Doppler abnormalities. And if they're there, we establish that there's early onset fetal growth restriction, much like the consensus definition that we now use. And as long as these are okay, we should just be very aware, alert, and have these mothers come in more frequently than other times. But once you establish that the situation has progressed, and particularly when the umbilical artery becomes abnormal, so for instance above the 95th percentile, or particularly when there's absent or reverse end-diastolic flow, you need to bring your umbrella, which means you need to prepare for an imminent delivery at some point in time. So this is when we admit our patients, when we give them corticosteroids, and we start also with increased monitoring based on CTG and ductus venosus. And then, of course, when it's about to rain, when we have our and then we prefer to actually use our radar rather than sticking our hands out when it's actually raining, meaning there is actually hypoxia. We perform a cesarean section, and in our case, we indicate this based on ductus venosus and the really abnormal CTGs. And of course there's some practice variation on the exact timing of all this between centers, also in the Netherlands, but also internationally. But sometimes it helps to think alongside of this analogy. And this is also something that is sort of being condensed in the ISHWAC statement with this nice graph, where it's also where, of course, again, all the gestational age is also taken into account for your threshold to deliver a fetus. I'm not sure about time. How are we? Yeah, all right, good. So I've been talking to you about this rather one-dimensionally, because I've been talking about gestational age separately. I've been talking about ductus venosus separately, short-term variation, but this is, the human mind is rather limited, isn't it? So we are able to maybe weigh 2 or 3 in a rather arbitrary way. And so the current project that we are now doing based with European funding is FGR Pods, where we are developing a decision support tool to determine optimal timing, trying to weigh a lot more factors and trying to actually make it a little bit more rational. We'll be collating lots of data. We'll be doing it based on a clinical trial in 800 patients. So that's the SAFE FGR trial, where we'll be comparing whether or not to use the CCGG, so the STV. And so then we'll have the answer to, is it actually better to use CCGG? And then while we are doing this, we're also collecting lots of fetal heart signals, among those with fetal EKG. So a lot more detail on all the levels. We'll be collecting biomarkers, including microRNAs, and of course the more usual placental growth factors. And then we'll be using all those data to collect, to try to develop a decision support tool that is multimodal and will really help us. I'd like to draw your attention to fetalgrowthrestriction.com, which is a website that may be of help to either your patients or to yourself, with a lot of information, and also about the trial, actually. And also a shout out to the research group who really motivates us to do all this, all these young people who are willing to spend their talents trying to solve the same questions that we do. And we are really grateful for that, and particularly here, Marielle, Victoria, and Bushra, who are in the FGR POTS project. Thank you.
Wessel, thank you so much. That was a fantastic tour through early onset fetal growth restriction and just where we've come from grit to truffle to where we're sitting with the consensus statements, and now maybe this implementation work through FGR pods. So it's fascinating. I was dying to see a difference because about the steroid timing by umbilical artery Doppler, because I think we've all moved from just in case to just in time for steroids whenever we can, because we have concerns about it being given too early and therefore being ineffective, and then exposing to repeat doses, which may not be of benefit to the baby in the long term. Yeah. But you didn't see any difference at all, even though there were differing guidelines, if I'm right. So what's the deal here? Do clinicians just not follow guidelines? That would be a surprising observation.
Yes, no. So of course, if you are in the earlier give it early group, then some of the patients will already have developed absent and reverse end-diastolic flow. But I think the sad message to that is that we are really poor at timing, because both groups were not as good; they were as poor in timing. And I entirely agree with you that giving it too early or just in case give it is really a missed opportunity to have maximum benefit of it when you give it early. And maybe I should say that particular project where we looked in this was from a colleague of mine in Erasmus, so Rotterdam University, who is we're very grateful that we have a very good collaboration in our small country. And this is actually one of the goals of that project, not just again to make this comparison, but also to look at it in a multimodal dynamic prediction modeling, and with that try to improve the timing of corticosteroids, because I think there's a lot to be gained there.
Absolutely true. And I think the other thing which you brought out sort of early in the presentation was just the early onset fetal growth restriction and the association with hypertensive disorders. And this makes it a bit more tricky to work out when's the timing of delivery, because if you've got coexisting preeclampsia, or if preeclampsia evolves, then that is going to shorten the latency from the time of your diagnosis to the time of delivery. I think, in fact, in truffle, about 50% of them develop preeclampsia, same with the heparin trial from the Spanish group. And the corollary is also true. Early onset preeclampsia, you are likely to have fetal reasons for delivery in half of them. So I suspect that partly explains the variation in timing. Can I just ask a question, and I'm going to get to the audience very shortly. I gathered, did I read it right that from the time that you've got an elevated UA above the 95th, you'll bring them into hospital and give them steroids at that point? Is that Netherlands approach?
There was, I think that's the variation that's between the centers. So in our center, we would only do it at absent and reverse end-diastolic flow, or of course if there's a maternal indication. But some centers would already have them come in for that.
Great. Okay, let me have a quick little look through the questions. We're getting a question about how useful is the uterine in monitoring, and does it impact timing for delivery?
So in my experience, it's not really useful for monitoring, but it is very useful for the differential diagnosis. So if it walks like a duck and quacks like a duck, and the uterine artery being part of that evaluation sort of differentiates between is this a very small fetus who has a problem with cytomegalo, or is this a placental origin? And that also then helps in identifying when to see this patient back again.
And this leads a little bit perhaps onto the next question about just very early onset FGR, say less than the third at 20 weeks. What's the role of uterine artery to stratify the risk in that group? And can I ask a question of, if it's normal, in the Netherlands, would you offer exome if you're offering genetic testing to that group?
Right. So it helps you helps you sway looking into other causes more often. The tricky thing, of course, is that if you have an abnormal fetus because of genetics, it may also be that the placenta that this fetus has built, because as Sanne said, it's a kind cake.
Yeah.
It's a child cake.
It's a fetal cake.
Yeah, and so it may actually be that this fetus also has a placental problem. So it may not be entirely possible to make discrimination because of it, but we definitely use it. So if it's just a small baby, and everything else is normal, you would be more likely to go to genetic testing than if everything looks like a placental problem.
Yeah, great. Danny Tucker's asked about timing of magnesium only when delivery decided. That would be our view, that we will give magnesium, except of course in the setting of preeclampsia, but for neuroprotection.
And maybe one pointer, it's never too late to give magnesium.
Yeah.
Well, of course, when the baby's born.
Yep,
but if you know how quick the effect is, the distribution, when you give it to the mother, it's like 1, 2, 3, and it's in the brain and she starts flushing. This is also how quickly probably it disseminates to the baby. So even if you've forgotten it and now the woman's in your theater, you can still give it.
Yeah. Great. And one final question from a science geek like me. Great presentation. What microRNAs are you looking at? And how did you decide which ones and how did you identify them?
Thank you. So our Victoria, who's in the middle on the right side of the screen, is our PhD on that, and she has just finished her review. This is a difficult thing because there's not one microRNA now that really stands out as a candidate to use for increased placental damage. So we are deciding on it now. Of course, the samples are coming in, and we need to make a decision quite soon. So if you have an idea, please reach out, and otherwise we'll just have to do with what we had from our systematic review.
Biorepositories and ask them. Yeah. Okay. Fantastic. Look, thank you so much. Absolutely fantastic presentation and wonderful to have you with us in person. Thanks so much, Wessel.
Thanks for having me.
I'm going to hand over to Adrienne.
Okay. Great. Can everybody hear me okay? All right. I do have a slight lack of voice, everybody online, because it's been a busy week. So I'm going to talk to you today about fetal growth restriction after the second stage. And we've heard from our amazing speakers so far about the placenta and the pregnancy. So that covers 9 months. I've been asked to talk about following that. So I'm now covering 28 days and the rest of your life. So settle in, no pressure. 25 minutes. Okay, so I think we've already heard about definitions and we know about the Delphi work and those early and late onset definitions. But I think in summary, we are talking about pathological mechanisms and non-pathological mechanisms when we're thinking about the baby that we meet after birth. So those babies who are constitutionally small versus those who have not met their growth potential. And it's a heterogeneous group. And as we've heard already, whether you're actually growth restricted depends on your placenta, first and foremost, issues around your genetics, around maternal health, and about the baby. So when we meet this baby after birth, just move back. When we meet this baby after birth, we need to work out which of the conditions the baby has. Is the baby small for gestational age and is normal? Is the baby growth restricted, or is the baby appropriate for gestation? And I think any of us who are in this area will be used to seeing this picture. And we would ask our students, which baby are you most worried about? And often they pick the baby on the far left of the picture. The baby that we'd be most worried about in terms of health span and life trajectory is the baby in the middle. So on the right, we have a healthy, appropriately grown term baby. And on the left, we have a healthy, appropriately grown preterm baby who is small for gestation. In the middle, we have a term growth restricted baby. And these babies are at particular risk both during labour, in the first few days and weeks of life, and long term, which we're going to talk about tonight. Oh, if I can move my slides, what am I doing? Tech help? Okay, no, got it. Just not pressing hard enough. All right, so that growth restricted baby, we can clinically work out whether this baby has failed to meet his or her growth potential by looking at the state of the baby. So whether there is asymmetrical growth restriction, extra skin, poor muscle mass, loose and easy peelable skin. Often those babies are described as looking a little bit overcooked. Sometimes they have an absence of buccal fat. So one of the things that is often described in a growth restricted baby is that they look a little bit like an older person. So when they lose fat around the head, the only place that you lose it from is your cheeks. So they have this triangular appearance that can make the head look abnormally large compared to the rest of the baby. So all of these things are definitely clinical findings, but they can be quite difficult and subjective in terms of working out, is this baby actually growth restricted or not? So obviously the other thing that we use are growth charts, of which there are a lot. And we're not going to get into which growth chart is the best today, but essentially if you're using growth charts, you need to use the same one. And if you're a pediatrician or your GP or you're a child health nurse, you need to keep using that same one to plot that baby's chart over time. They will all plot in a slightly different spot, and that might need you to make different decisions. So if we're thinking about a growth-restricted baby, in very basic terms, those babies are often asymmetrical on a growth chart, whichever one you use, meaning that the weight is out of sync to both the length and the head circumference. And this is a particular issue if you haven't had long-standing early onset growth restriction. This is a picture on the right of a baby who's got reduced subcutaneous fat, and you can see those kind of saggy-baggy skin around the knees and in the inner thigh. Often these babies are either on the 10th percentile or above, so just having a cutoff won't tell you about growth restriction. So how else can you work this out before you have a baby who is metabolically unwell with a low blood sugar? So one of the things that's been postulated in terms of working out if the baby's growth reduced after birth and before you wait on your placenta report, which will pop up in 10 days' time, after which you've already had your problem with hypoglycemia, is doing early assessment using non-invasive techniques such as air displacement plethysmography. So that was a mouthful with my croaky voice. So this is something that uses the difference in pressure to work out percentage fat-free mass and percentage fat in terms of the baby. And we know that this can be more accurate than just looking at birth weight percentiles when you think about neonatal morbidity. So there's been work done in several sites now to look at if this correlates better than your actual birth weight. And in our centre, we did some longitudinal studies looking at morbidity as a combination of poor feeding, hypoglycemia, and admission to the nursery, and found that this measure actually was much better than birth weight. Following that, this was put into clinical practice, and we created some norms from around 7,000 babies in that cohort. Unfortunately, we don't do this as clinical practice because the room that the PPOD was located in was taken over in COVID, and has never been returned. But this is commonly used as a research measure in many studies to try and use something that is less invasive than DEXA or MRI, for example. And in this study in Vienna, they looked at body composition of babies that were born early, but divided those babies into appropriately grown, small for gestational age, or having growth restriction. And they found that there weren't really differences in the trajectories between the small for gestational age and the appropriately grown, but there was for the IUGR group. The IUGR group also had much lower fat-free mass. So that's important when you're thinking about what we've heard already in terms of growth during the pregnancy and poor placental function. So having that reduction in subcutaneous fat and fat-free mass means that you have less energy reserve to tolerate things like labour or any illness that you might have at the beginning of life, for example, early onset sepsis. Growth restricted babies are more likely to end up with things around hypoxia and the intrapartum period that might lead to persistent fetal circulation, meconium aspiration, and birth asphyxia. They can also, however, have renal dysfunction, even if they're not born preterm. So if you're growth reduced and your organs and systems are growth reduced, you will have less glomeruli, so you will have less resistance to any renal insults in the beginning of life. They will be more polycythemic, and that can also lead to problems in terms of low sugars and hyperviscosity. You can also have used up your sugar to protect your brain, because that's the only thing your brain is using at the beginning, and that can lead to seizures and additional problems, as well as not being able to have energy and losing temperature more quickly. So a lot of issues, even if you're not born early, just related to not having normal growth. So next up, we've done the first month. Now we're going to go into childhood, and we're going to try and get through all of this in the 25 minutes. So if we look at infant and childhood related to growth restriction, then we're really thinking about developmental and intellectual outcomes. And what we know about babies who are growth restricted from a lot of the animal work, particularly in lambs, is that these brains of the babies who have poor placental function don't develop normally. So just like those kidneys that don't have enough glomeruli, the brain has less neurons and also has a much more fragile integrity of the white matter. Glial cells can be activated, which are also activated in chronic hypoxia. And all of that affects the neurovascular bundle. And this is some of the understanding that's leading to some of the newer work in stem cells for neuroprotection that I'll mention a little bit later. So if that brain hasn't developed normally in the pregnancy and in early life, this can lead to ongoing issues in the beginning in terms of motor problems, cerebral palsy. It can lead to problems with cognitive development and educational outcomes. It can also lead to externalizing behavior disorders and understanding as children get older. Many babies who are growth restricted are also preterm, and many of those are also planned births for a reason of placental dysfunction. We're going to come back to that a little bit later also. So we've obviously heard about this already from Wessel, but just to point out that the group from a developmental outcome point of view at 2 years that appear to have the highest rate of normal development in that comparison is that group from Truffle, where there is the CTG and looking at the ductus venosus. And I guess this would be standard practice for many of us working in tertiary centres. You can see that obviously plays out, and Wessel's already shown this that the odds ratio for surviving without neurodevelopmental impairment for those early onset growth reduced babies is definitely better also in that group. So if you're actually growth restricted at the beginning, we know that's important, but then we need to know what happens as you grow through life. And as I mentioned before, many of us in the pediatric or early childhood space are plotting the growth of those babies every time we see them. The parents are often very focused on this trajectory because they've often come out of a pregnancy where they may have had at least one scan a week, potentially one scan every couple of days. So they're also very focused on the trajectory of these babies over time. And so this study here is from the Generation R study, which is a birth cohort of around 9,000. And in this study, they looked at the babies who were small for gestational age. And then they grouped those babies into when did they become small for gestational age, when did their growth fall off, and whether it was particularly related to the mid-pregnancy period or not. Then they looked at age 6 at both IQ and externalizing behavior disorder in terms of ADHD. So group 1 are the group that had consistent no growth in the pregnancy in that mid-trimester. So that very significant placental dysfunction with no sort of recovery that we've heard about actually from both Wessel and Sanne. They've put adjusted and unadjusted rates here, but what you can see here is IQ difference compared to non-SGA across all 3 groups, but most marked in that group that didn't have any mid-trimester growth in terms of the trajectory. So you can see that for IQ, and then here for ADHD symptoms, in the unadjusted, it doesn't reach the point of no significance. Once adjusted, this is not significant, but you can see the trend is still there. So that growth trajectory of not having any weight gain in that sort of middle of pregnancy, very important. So the next thing from the childhood point of view, childhood education, is that thinking about iatrogenic delivery, regardless of what you use to predict your delivery, for whether the babies were small or not, whether you knew they were small or not, and how those children did at school. And this work by Roshan Selvaratnam from Victoria is a population-based study where they looked both at birth weight and centile and outcome, but also at decision-making. And this nicely shows that decision-making also affects outcome as well as size. So this first figure is looking at overall size and NAPLAN scores. So for anybody here not from this country, NAPLAN are mandatory educational assessments, mainly in literacy and numeracy, that are done at set times during primary school and high school. So grade 3 and 5 are in primary school and 7 is in high school. So you can see here there is a dose response related to size and the likelihood of having a poor outcome on those NAPLAN assessments. But what's really interesting about this population-based study is looking at these different groups. So they divided this into 3 groups in terms of iatrogenic delivery.
Okay, all right. Very sorry for that minor interruption there.
All right.
Is there any presentation which is not complete without a computer reboot? Absolutely not.
No,
Carry on.
Not at all. Okay, right. Okay, so what's really interesting about this is just the way that they looked at whether if you had suspected growth restriction versus not suspected growth restriction, and then if you were suspected antenatally, whether you had a planned birth or not. So if you just have a look within the red box, The very interesting differences are between whether you were iatrogenically delivered for suspected growth restriction versus having no suspected growth restriction. And you can see here, if we look at less than the third percentile, where there is an adjusted odds of developmental vulnerability, which is another assessment often used in population-based studies, used at the beginning of school. So a 36% increase in developmental vulnerability. Whether you were at a lower NAPLAN grade was also much greater if you were in that iatrogenically delivered group. And that also plays out a little bit if you look at the more than the 10th percentile, but is in NAPLAN grade 3. So I think this is just a very nice way of being able to say that our decisions, not only does the growth restriction have a part to play, but the decisions around it also have a part to play. Okay, we're going to adulthood now and more than 18. And I cannot do this story without telling the story about David Barker, but also about Ethel. So many people will know the story about the Barker hypothesis. David Barker was a professor of epidemiology at Southampton and first documented the fetal origins of adult disease in the Lancet in 1989. But none of this would have been possible without the help of Ethel Margaret Burnside. She was a chief midwife in England. This is the only photo of her, apparently, when she was actually 17. And the reason that any of this hypothesis was able to be discovered is because she had meticulously gone around Hertfordshire documenting the birth weights of babies and writing them meticulously into handwritten books. And it was because of that that David Barker was able to look at birth weights and later deaths due to cardiovascular disease. And the reason that was all being documented in Hertfordshire is at that time in England, the stock of babies and young adults in Hertfordshire was very poor. And they had about 1 in 10 people with poor nutritional status. And they had a real issue with being able to sign people up to the war because people were undernourished and unfit. And so that's why they had appointed a chief midwife and collected all of these birth weights in the first place. So this graph is known to anybody that knows about the fetal origins of health and disease. And there's a correlation in that data between low birth weight and later deaths from heart attack or stroke. There's also an uptick there you can see with bigger birth weight, but at that time, this was less known. Why does that happen? Well, it's related to metabolic programming and the fact that the fetus adapts in utero to this poor placental function and has this thrifty phenotype hypothesis, and then is born into a land of plenty with a McDonald's on every corner and is not metabolically programmed to cope with that change. We have lots of great data that is very longitudinal that tells us that this is true. Initially, like all great hypotheses, nobody thought this was true. And it's only in the more recent years that the actual mechanistic understanding is much clearer. So we know that in the follow-up of people who experienced the Dutch hunger winter, and when they were examined in their 60s, they had reduced methylation on the insulin-like growth factor 2 gene. That was much, much more significant if their mothers had been exposed to starvation because of the hunger winter in very early pregnancy and to mid-pregnancy. So again, similar as we were talking about earlier with those growth trajectories with the early and mid-pregnancy reduction in growth. These same changes were not seen for people that had rations and hunger and starvation in later pregnancy. So that relates to epigenetics and genetics. So if genetics are the alphabet of life and our DNA sequences, then the epigenetics are the grammar. And these markings and the switching on and off of genes can modify what they do and then how you respond later in life. Okay, so I'm just going to go through very briefly. This is from a wonderful overview about long-term consequences of growth restriction by Fatima Crispy from Barcelona. So 2 main mechanisms, metabolic changes and cardiovascular remodeling in terms of how growth restriction plays out into adult life. So we've talked about placental insufficiency, and we've talked briefly about those epigenetic changes, beautifully documented in those long-term hunger winter studies. So from a cardiovascular remodeling perspective, we know that there can be cellular changes, there can be tissue changes, and that can change the shape and function of the heart. And we now know that there are ways we can measure these things early in life as a marker of long-term health. So there are many long-term studies, such as the Young Finn study, looking at some of these measures early on, like early atherosclerosis through aortic intima media thickness. But we can also look at the structure of the heart and its size and shape, and follow that over time to give us a little bit of an idea of who might be much more at cardiovascular risk later on. So not just epigenetic changes in that developmental origins of health and disease, these cardiovascular consequences are very prevalent also. People have taken this sort of thinking to think about opportunities for correction or to optimize a heart-healthy lifestyle. And I guess one of the early things for babies is breastfeeding and paying attention to those growth trajectories, making sure that if you are born early or growth restricted, that there is some way that you will have blood pressure measured over time. So this is really not well done at all. And we've just finished a Penzance conference. The kidney group were there and very active and are really sort of pushing for much better monitoring of these things over childhood. And I guess because in childhood, the blood pressure changes are very small, of the order of around 2 to 5 millimeters of mercury. People haven't taken this on as a kind of monitoring strategy. So we do a lot of long-term follow-up for preterm infants. We don't do as much for growth-restricted infants. And thinking about these things earlier is likely to become more important with time. Because with early screening, you could have early treatment, avoiding some of the things that cause cardiovascular risk in everybody, but particularly thinking about that if you're born growth restricted would be important. How to do that, obviously, quite tricky. So we have this perfect storm with a small baby, this issue about programming and epigenetics, cardiac remodeling, but also postnatal abnormal nutrition that kind of combines to some of these later life problems. And there are plenty longitudinal studies showing risk of metabolic syndrome, type 2 diabetes, abnormal triglycerides, early dementia, etc. And I think whenever I do these sorts of talks, I reflect on the fact I'm Scottish, got a family history of heart disease, I was growth restricted. So I think these things are important and a bit alarming, but you can change your trajectory. Okay, there is always hope on that note. And I was going to add one more slide in today, but I didn't have time with all the Penzance things that were going on. So I'm going to talk to this one and I'm going to mention a couple of other things. So in terms of hope, we've already heard about some of the agents that people thought would be really useful in this space. And I guess sildenafil was one, and the Strider studies and the more recent iSearch study have not played out in the way that was hoped. We do have new work happening around stem cells for neuroprotection. A lot of that is being led by the team in the Ritchie Centre, or Hudson, in Melbourne, and the Cerebral Palsy Alliance. We also have the Protect Me trial that I know is finished recruitment, but their primary outcome is long-term follow-up of the babies. That's led by Kirsten Palmer at Monash, and that will be extremely interesting and important. The slide I was going to add was around better markers for timing, who is safe to stay and for which pregnancies it's time to go. And the TimTam study being led by Tui and Sue and Stephen, using SPINT1 as a test of placental function, will go some way towards that. The PLANES trial, led by Alex Heasel and team, explored the feasibility of a biomarker monitoring system to guide planning of delivery using PLGF-S-FLIT. And unfortunately, that study, even though all of what you've heard today would say that a biomarker-driven study is going to be the next frontier, didn't recruit to its 100 participants. That was just published earlier this year. So we have a way to go to work out around timing of birth and decision making. And we also have a long way to go in pediatric care to work out how you can actually change these trajectories, even though you know they're really important. So thank you very much. And I'm sorry if my voice was too lost to be able to hear it online.
Absolutely not, Adrienne. In fact, you've noticed that we had a battery dysfunction just so that we could give you a little bit of a break. So I hope you appreciated that. We've got your back covered. Thanks. Hey, we've gone a tiny little bit over time tonight, but what a fantastic twilight we've had tonight. That was just a beautiful summary of where we're up to with newborn care. We'll just jump onto a couple of the questions. So this was just a note for, that was, I think, a comment about the undernourished Barker hypothesis. Yes. Will the talks be available for on-demand viewing? Yes, they will. It's better than Netflix, what we're offering here. So yes, that will definitely be absolutely free and jumping into your inbox in the next sort of 48 hours or so. So Adrienne, the stem cell story is exciting. The melatonin story, we need to wait and see. Tell me, we had a CP twilight a few months ago, and I was absolutely fascinated to hear the stem cell story. Are we able to, is there compassionate access for stem cell therapy for babies at risk of cerebral palsy as of now in Australia, or is this still an evolving space?
Well, that's a very good question. So I'm sure in that twilight, you would have heard the stories of people having to travel overseas and raise money to go to the US. So I think, look, at the moment, I think it's a little bit aspirational. I think it's not readily available unless I'm not across that. And I think there's also been issues in trying to do some of these trials. There was a planned trial for both neonatal stroke and also for neonatal neuroprotection, and the availability of the cells for both these studies and the companies producing them has precluded those things occurring. So I think definitely needs partnership between industry and scientists and researchers to move forward.
Exactly.
It's PPA are advocating.
They completely are. I mean, I think partly because the data is actually quite compelling, and also because, as you say, there are families who are desperately trying to access it, sometimes not down the most regulated or best pathways. And I think that's how they managed to get compassionate access for a patient at Monash, I believe. But whether, if anyone on the chat knows, please jump in. But I think it is case by case compassionate access. It's certainly not standard of care at the moment, but it's what's coming next, I think. All right, guys, what a fantastic evening. So I think let's just recap. What we know, fetal growth restriction, perhaps one of the most important syndromes of obstetrics. It's a leading risk factor for stillbirth, for neonatal death, for neonatal morbidity, for childhood and adult outcomes. We've heard a beautiful summary of placental pathology, and maternal vascular malperfusion is certainly the most common contributor to it, and also associated with hypertensive disorders of pregnancy, which in itself has maternal long-term risks as well. So very important placental biology. I think we've all established for ourselves that smallness is not fetal growth restriction, and the added measures that we're really looking at are things like growth, Dopplers, biomarkers, neonatal measures, placental size, weight and pathology. We've heard a wonderful summary from Wessel about early onset fetal growth restriction, relatively easy to diagnose. Tonight we've covered that treacherous territory of surveillance and triggers for admission, for steroids, for delivery and early onset fetal growth restriction, trying to balance avoiding stillbirth and asphyxia with avoiding excessive prematurity. I think tonight we've also recognised that therapeutic deficiencies are a problem, and that there's a deficiency of therapeutics, and there are new things on the horizon, and we continue to look for things that might be safe and effective to use in pregnancy. Term FGR, much more challenging to diagnose, and although while the intervention looks very clear that you just deliver the baby, I think what Adrienne's shown us is the important data of making sure that we are giving that intervention to the right patient at the right time, so we are doing more good than harm. Overall, still much more to learn. At the Dutch Consortium, I can't wait to hear about that over a drink with Wessel and Sanne. Standardisation of size, growth and guidelines will probably be the focus of our new consensus statement, so don't forget to fill out that survey if it comes to you. And we're also hearing more about what are the targeted surveillance and therapeutic options in the newborn period. So, brilliant, Twilight. Thank you to all our speakers, particularly to Adrienne, who as president of PERSENS has just had a massive, massive week and did say to herself, why did I agree to do this? And it's because you can't say no to me.
You can't. I know.
I'm irresistible and you're irresistible. So thank you so much for joining us for Twilight. We'll obviously have a little hiatus because there's going to be school holidays, Easter holidays for many. So travel safe, have a great break if you're having them. And we'll be back in about 4 to 6 weeks' time with the next Twilight. So thanks so much.